Two people. If you can start.
It will increase. Sir, shall we start?
Yes. 8:30.
Yeah.
Please.
Very good evening to everyone. I welcome everyone for this panel discussion on medico-legal issues in surgery. I request Chairman Dr. H.V. Shivaram sir to formally welcome the gathering.
Thank you, Dr. Chandrasekhar. It's my great pleasure and also privilege to welcome all of you to this very important meeting on the medico-legal issues in surgery. This is the problem all of us face day in and day out. And to enlighten all of us, we have a galaxy of experts who are not only the experts in the legal issues whenever it is occurring, and also the medical problems which some of them might have faced, they will also share, and also all of us also can share our experience when there is discussion. So I request Dr. Narayan I.Hebsur to moderate this session and take over. Meantime, everybody can mute and listen to the experts, and at the end, let us have a good discussion. I request everybody to stick on to their time so that we will finish the session on time. Thank you. Over to Hebsur.
Thank you, sir. I'm Dr. Narayan I.Hebsur here. I'm moderator for this session today. Thank you for giving me this opportunity, President Shivaram sir, for conducting this program. We have a panelists who are really experts in these various issues, medical issues. I welcome the panelist, Dr. Venkatachala, who's going to speak about the cases what we face come across day to day. And we have, I welcome Dr. Prabhakar sir, who is a KMC chief, and he will enlighten us about how KMC will see these issues. And then I welcome our Dr. PAVAN Patil, who will enlighten us about what brickbats we are getting in the hospitals and what problems we are facing in the hospitals. Next, I welcome Dr. KUMBAR sir, Shivkumar Kumbar sir, who is an anesthetist and a lawyer also. He will enlighten us how to face these issues. All of them will be speaking for 10 minutes each. After that, we go to have a 20 minutes of questionnaire session, which we can take it up one by one. If anybody has any questions, kindly share your questions on the chat box so that we can take it one by one. I request and I welcome our scientific committee chairman, Dr. Kalaivani madam. And now we can start, I think. So, President sir, shall we start, sir?
Sure. I welcome one of our very senior member, Dr. R.D. Prabhu sir. We are really honored to have you here, sir. Welcome to you, sir.
R.D. Prabhu sir, welcome, sir. Thank you, sir. Now over to Dr. Venkatachala. Kindly share your slides and give your presentation for 10 minutes.
Martin has to share.
Martin, kindly go to the slides of Dr. Venkatachala.
He's doing.
Just everybody to mute.
So, good evening, everybody. So, I try to put around 4 cases. Two of them are the first 2 cases are my own personal experiences, and the next few cases are, what were examples for me to modify the way I practice my clinical, surgical practice. So, can we go to the next slide, please? So this was a case of a sudden post-operative death. Everything went fine, but unfortunate. So unfortunate things can happen in surgery. So we don't promise anybody anything. when we operate. So we are not gods. We are only standing in between the patient and God. So a 35-year-old gentleman, an executive, he presented with locally advanced neglected squamous cell carcinoma of the buccal mucosa with bilateral neck node metastasis, means even level 4 neck node metastasis. So the skin was, dermal lymphatics were infiltrated on the cheek skin. So we gave 2 cycles of neoadjuvant chemotherapy, as we had good experience of giving neoadjuvant chemotherapy, because this disease was already a stage 4A disease. And there was very good response to neoadjuvant chemotherapy. So because of this thing, we planned, discussed, and did a left composite resection. The central arch of the mandible was saved so that we avoided tracheostomy, with bilateral modified neck dissection and a double microvascular free flap reconstruction, which it included a composite free fibula reconstruction for the inside of the oral cavity and the mandible, and a left cheek skin was reconstructed using a radial artery forearm flap with a prior written informed consent. So the right neck drain was removed on the 9th post-op day. The left drain was kept in situ because there was some salivary leak. Minor, very minor leak, very few bubbles. But the patient didn't get discharged in the morning. By afternoon, by the time they arranged money for discharge, he developed a sudden neck hematoma. I was busy somewhere else. So in the hospital, he had a neck hematoma. So because he was developing a swelling, they took him to the ICU. In the ICU, there was a ENT surgeon. He did a tracheostomy. This patient developed ventricular tachycardia and he was panicking. So you can't intubate through the mouth because of obvious reasons and some trismus. So CPR was done with the tracheostomy in situ. He went into ventricular fibrillation and expired. By the time we reached, it was already around 15 to 20 minutes. And it's unfortunate. We explained the relatives. We explained the brother. He knew us for around 3-4 months.
Unmute, Venkata.
Somebody muted me. So the whole team went back because we were called back from the hospital. When we went there, we were told that the brother has filed a criminal negligence case. Criminal negligence case was that the plastic surgery team, who were basically dentists assisting the plastic surgeon, they were supposed to see on that morning. They got busy with some other work. They said there was nothing great that we were to do, only it was a visit. If he is fine, he can get discharged. We will see him in 2 days for the dressing of the donor site and the radial artery forearm flap donor side dressing. That's all. They didn't have anything more to do. So that was one case. Next slide, please. This was another case which I came across. One of our co-brothers' relative, a 48-year-old lady, she had fibroid uterus, DUB, she was troubled, so she went to a government hospital and underwent hysterectomy. Post-operatively, after some days, she had some severe pain in the abdomen, was not able to eat, she went into weight loss. She kept going back to the operated surgeon. The operating surgeon told it could be some infections, and analgesics and antibiotics were given. As the pain was not relieved, she went to another doctor. This doctor thought he will do some investigation. He did a CT scan. CT scan clearly showed there is some foreign body in the right iliac fossa, very leftover mop. So then they contacted me. They came to me, and when I did the surgery, so I found that there was definitely a mop in the center of a mass in the right iliac fossa. When I tried to dissect the mass, I found that the mop was all bile stained, means there was a small perforation in the bowel, but fortunately there was no obstruction, so she was able to eat and pass stools. But definitely there was a perforation from the mop. It was very tough to dissect that area because of the 2 months inflammatory process. So we had to resect that part of the cecum and ascending colon and the terminal ileum and did a ilio-ascending colon anastomosis. She went home fine. One of the brothers was a lawyer. The patient's husband's brother was a lawyer, brother-in-law. So he took the mop, sealed it and kept it with him, went back to the doctor, asked for compensation. The doctor refused. So then complaints went to media, Health Ministry, State Human Rights Commission. An inquiry was set up. A lot of problems happened. The doctor was about to get suspended and then he had to pay compensation. And surprisingly, in that compensation, what I got was 20,000 rupees for my operating charges, but the lawyer got around 3 lakhs. Next, please. Another case is a hysterectomy done without patient's consent. Many of us know about this case. 44-year-old unmarried lady. She didn't have issues. She was being evaluated for a pelvic mass, which was mainly due to menorrhagia. She was taken for diagnostic laparoscopy. There was endometriosis found. Actually, the uterus was normal, not the ovaries. Endometriosis was found. Operating surgeon told that the mass is stuck to the uterus and took consent to the mother and did a hysterectomy and bilateral salpingo-oophorectomy. Post-operatively, the patient panicked. She was not happy that her consent was not taken. So she was the problem here is that the person who is around close to her 40s, in her early 40s, was neither a minor nor mentally challenged nor incapacitated.
3 minutes left.
Her consent was not taken and then the surgery was done. Next slide, please.
Dr. Venkatachala, please speak a little loudly.
Is it?
Yeah.
I think, okay, I will try to increase my voice. Next is a pregnant lady was admitted 2 weeks before her EDD with excruciating pain. So cord around neck was suspected and an emergency LSCS was performed. A live baby girl was born. During transfer of the patient from the OT, there was a record in the case sheet that some fall happened. Nobody clearly mentions what is that fall. Either it was during shifting the patient from the OT table or shifting her to the ward bed. After 5 hours, anemia was recorded. Patient was having a high RBS. So insulin was given. Sugar levels reduced to 56. A physician was called because of hypoglycemia.
2 minutes left.
And he said
2 minutes left.
he suspected a septicemic shock in a post-cesarean section delivery. Because there was hypoglycemia and there was hypotension. Nobody suspected that the patient had a fall and could be having hemoperitoneum. Wherever, no, from the uterus, from somewhere, from the stitches of the uterus. The patient expired 2 days later. The post-mortem was conducted and then it reported as antemortem injuries on the right side of the body and 2.5 liters of blood in the abdominal cavity. So obviously the case went against the doctor. In the first case, what we did, my case, the composite resection, after 5 years of fighting and spending almost 1 lakh per head, around 5 lakhs to the lawyer, the court ultimately, KMC exonerated us. After that, there was no counter case filed in the court of law. Because of the consent, and documentation really helped us in that case. Okay, please, thank you.
Thank you, Dr. Venkatachala. Now I request next panelist, Dr. Prabhakar sir, who is a KMC chief, would like to highlight and give us the it's how to go about them. These 4 cases, can you just display the case also again? 1, 2, 3, 4, please.
Martin, you can go to the slides.
Slides.
Dr. Venkat's slides.
1, 2, 3, 4.
I think Dr.
Prabhakar sir slides. Yeah. Sudden death, post-operative death, 1 case. MOP left. Third one was hysterectomy case. 4th one, fall of the patient from the table or trolley. Okay. Now I request Dr. Prabhakar sir to please present his slides and present how to go about them.
Good evening, everyone. Actually, most of the people, they think KMC and IMA are same. So actually, that is the reason why I put my slides like this, because KMC it is quasi-government and it is commanding, whereas IMA is a non-government organization and it is demanding. So the principal purpose of the medical council is to protect the health and safety of the public by providing mechanisms to ensure doctors are competent and fit to practice. Okay, so the main functions are usually the registration and other things, and to promote lifelong learning for doctors and other things. Ultimately, the any case which will come to the Karnataka Medical Council, we will, before registering a case, we will ask the doctor to give an explanation for the whatever the complaint we receive. So, if the prima facie says that it is registrable case, then we will register. And if the complainant feels that some more explanation, or the KMC feels that it has to be registered, then we will register, and we will definitely go through all the conversations between the complainant and the respondent. I think for the first case, the first case. Not my slide, Venkatachala's slide, please.
Not in Venkatachala's slide, first case.
Hello. Yeah. So in the hello.
Yeah, you can continue, Prabhakar.
Yeah. Now, because in the council, if you see that what was the first case? First case is
Hysterectomy.
hysterectomy.
No. It
No.
was not hysterectomy, sir. It was the death, sudden death.
Sudden death.
postoperative
Okay. Yeah. Sudden death can happen for so many reasons. In fact, we lost one of our friend today, the afternoon. It was sudden death in the home itself. When the patient had so many morbid reasons, and if we have died postoperatively also, if you have proper documentation, and if you have even taken the consent for all the whatever the procedures and other things, and if you have explained the things to the patient and the
7 minutes left.
and if you have recorded properly, I don't think it will be a problem in the court of law. So there may be, at the time of death, there may be some problems you have to face. That is because of the grievance of the patients. But in the court of law, definitely, if you have a proper documents, and if you have done in your conscience, you have not done any wrong things, definitely that will not be a problem at all. So it is only thing you have to prove whatever the complainant is praying. So you have to listen carefully that prayers, what he has prayed, and those things you have to answer correctly, and you have to show the documents properly. So I don't think there will be any problem in this case if you are, even if it says it's a criminal case. So definitely it will not be there will not be any problem.
Sir,
So
can I add one thing, sir, here?
yeah.
The court observed, including the KMC, means observed that the documentation was proper.
Yes.
Nurses' documentations were proper, the consultants' documentations were proper, and court expects that complications do happen. But when it happens, first is you have to, in your consent form, you have to explain, including death complications can happen.
Definitely.
Second, when they happen, what was the action taken? Was there
Exactly.
any negligence when it happened? Thank you, sir.
Exactly. So
Yeah,
that
I'll add something. Yeah, in this very interesting case for the surgical, but in April 2021, Supreme Court categorically said death of a patient cannot, on the face of it, be considered to be a medical negligence. This is a very landmark judgment, and medical practice is not expected to be held liable just because something went wrong. or a misadventure happened intraoperatively or postoperatively, categorically it is ruled out that there is any medical negligence. But we are expected to some reasonable care, but no professional can assure that patient will come back home or can be revived after the CPR or other things. So as Dr. Prabhakar rightly said, documentation is very, very important. Other protocol has been followed are very, very important. And seconds of
5
event,
minutes
what you have
left.
done is important, sir.
Yeah. Next case, please. Next case. Next case. Second slide. Second slide in the Venkatachalas.
Martin, you have to be alert.
So mop left in the abdomen. So if you just say that it is a negligence. If you just say mop left in the abdomen is a negligence. But mop, nobody will keep and suture the abdomen purposefully. So that is a criminal thing. Mop left, and if he has seen or if he has identified, so he has to explain to the patient and he has to tell what are the complications, can the patient will go, or what is the next treatment. And so that is very, very important. Unfortunately, the first surgeon, I think he has not noticed, or it has gone, it has not, he is not aware of that there is a mop left in the abdomen. The second surgeon may be operated, and it is a duty of second surgeon also to show the mop whether it is really left. It is not that you are complaining against the first surgeon, but these things do happen in the practice. So sometimes left side surgeries, right side. So these are all negligence only. If you follow the protocol, definitely you will not miss all these things. So if you are not followed the protocol, so the things can happen like this. Unfortunately, the in a small and mid-sized hospitals, you will not have any this floor nurse or assistant nurse to note down what are the things they have provided and what are the things which are finally when before closing whether the count is there or not. So these things, if you have not done, so it is not documented, then definitely in the court of law it will be a negligence only. So I in a corporate hospital, definitely there will be one floor nurse will be there and an assistant nurse will be there. So there will be counting and other things. But in a small hospitals, these are the problems. They because they are not documented here. At least there they will document, and documentation will help you in the court of law.
So what happens here is that there is something called as WHO safety checklist. Every hospital must
Minutes
include
left.
it in the file, and they must read it during, before, and after the surgery. That is where you will not miss. Because we are not doing that, we are missing out.
But how many people are practicing that? That is also important.
NABH stresses on that, sir.
Yeah, you have to practice that. You have to practice that. Then you will not come across these problems.
Yeah, can I add something, sir, here? Yeah. Hello?
Yeah.
Yeah. See, yeah, many times it does happen in a general surgery or the, especially atomic pipettes, other things. Yes, the like saving the life of patient is paramount important, and the patient goes into pipettes, atonia. Many times we are bound to somewhere. Okay, that's a paradox. You can miss something over there. But having recognized it post-operatively, okay, if the patient complains something is going wrong, so that is very, very important. That time you can do the ultrasound, re-explore, nothing, no problem. But if you ignore it, the patient goes for some other surgeon, okay, if they do the ultrasound, if they do the CT scan, MRI, if they explore it, so if they find it, that is something like a gossip ibomia, okay, that time you are accountable. What I suggest is, even if they mop, whatever is removed, okay, you please see to that, it will be sent for the histopathological examination. Okay, many times it has happened so much that some septic mass or something, probably they may be accountable to the some gauze is left or something like that. Make sure that it will be sent for the histopathological examination. Especially in New Delhi, recently one case happened, Sweta Khandelwal versus Jain. Okay, even the Delhi Medical Council also gave an opinion that there is a gross negligence by keeping the mop and closed the abdomen, and even National Consumer categorically said that it's a medical negligence, deficient services, and they have been heavily compensation have been awarded to the tune of 20 lakhs, 30 lakhs, 40 lakhs. I think we must make sure that we follow the
0 minute
WHO.
left.
Next slide, please. Next slide.
Sir, I request Dr. Prabhakar sir to please complete your presentation. Then we'll all together will take the questions later.
Okay. I thought because in the KMC, I'm not just because I'm. What are the duties of KMC? That was my slides actually.
Yes, sir.
So that is actually the council will follow the usually the registration and determine what are the qualifications they have, and also what are the scopes of practice, and we are setting some standards and supporting doctors to uphold these standards, and also we are recertifying and promoting lifelong learning for the doctors, and we review the practice of doctors if there is any concern about performance, professional conduct or health. And of course, the council also expects from the doctors the care of patients. That is very, very important here, and respect the patients. And you have to work in partnership with patients and your colleagues. So act honestly and ethically. That is very important.
Martin,
And,
please show
accepting
sir
the
slides.
obligation to maintain and improve the standards. And of course, when you come to the next slide. So regarding the records, you must keep clear and accurate patient records in relevant to the clinical information. Whatever the clinical information, you have to document properly. Don't write just, I've seen so many case sheets, they are written only just diagnosis on the top. They are not written even the history or the examination findings. So unless you have a clinical information, that will not be a proper documentation. And what are the options you have discussed with the patient regarding their treatments, whether it's a medical line or surgical other things. And all these things, like what decisions you have taken and what they should be recorded in the case sheet. And of course, the consent and information regarding what is the diagnosis and what are the treatment options and what are the complications. All these things you have to inform the patient in their own language, and you have to take consent in their own language. Next slide, please. So you have to maintain the medical records at least for a period of 3 years from the commencement of the treatment. And of course, medico-legal, sometimes you may have to keep at least 8 years. And if there is any request made from the patients or an advocate, you have to provide the documents within the period of 72 hours. That is very, very important. And regarding the medical certificates, so nobody is following the protocol of the medical certificates. Actually, the medical council has given this thing record how the medical certificate should be there. So you have to mention the patient's name, age, everything, and one identification mark of the patient, and whatever the certificate, if it is for the medical leave. So you have to, depending upon the disease, so you may have to give up to 15 days or so. Don't give beyond 15 days. Otherwise, it will be very difficult to explain. And in the last, you have to put your signature and you have to mention your name and your KMC number. That is very, very important in the medical certificates. Next. So there are some unethical acts. I think everybody knows that you should not advertise unnecessarily unless if it is for the first time, or if you are changing your profession, or if you are practicing a new thing. So in that case, you can advertise, otherwise you should not. Then if you have any patent and copyrights, so if it is largely useful for the community, you have to disclose, otherwise it will become an unethical act. So there are secret remedies like nowadays, nowadays we don't see that. Usually you have to give the correct prescription with a capital letters and pharmacological names. And euthanasia, as you know, it is not practiced in India, but sometimes partial euthanasia, maybe it is advisable in some cases. Next. So misconduct, it is if if the regulations, whatever the KSCASI regulations, first you should know, and if you are not following that, or if you violate these regulations, that is a misconduct. And medical records, if you don't give, if they ask for this thing within 72 hours, again, it will be a misconduct. And if you don't display your registration number either in the prescription or in the OPD slip, so that is also a misconduct. You have to mention your registration number. Then, of course, sex determination test and other things. And when you are signing the professional certificates reports, you have to be very careful. Next. So punishment wise, where actually KMC doesn't have much power except for the removal of the registration of a person depending upon the gravity of the case. So up to 6 months cancellation of registration is there. So for the permanent, this thing usually it will go to the appellant authority, that is NMC. Disciplinary actions. So we will warn, and usually whatever the this thing is there, no. So usually we will announce in the newspapers that this fellow has left the guards and has done medical negligence, something like that. It will be by the in the newspapers. It will be published. So these are the important punishment or disciplinary actions we take. But based on this, so consumer case, if it comes, so they can use these punishments and they can charge heavily. I think briefly that is about the KMC, how it functions. I think case discussion, I think we can discuss later. Right? Thank you. Thank you very much.
Thank you, sir. Now I request Dr. Pavan to please come start his presentation.
Yeah, Martin. Good evening, everybody. I thank the President, Secretary, and Dr. Hebsur sir for giving me this opportunity to be part of this panel discussion. My topic for today is healthcare violence. We've been hearing a lot of incidents of healthcare violence across the country, and a lot of chaos and unhappiness over this topic to everybody. So a lot of things have been done through IMA to all other associations to have a uniform act against violence in healthcare, but somehow we are not being able to be successful in getting the central act, because recently in Rajya Sabha also the health minister, central health minister, said it is a state affairs and they need to have their own laws. So what is healthcare violence? Healthcare violence can be anything. It can be physical, it can be intimidation by gestures, cyberbullying, abusing verbally, harassments by the police and politicians, blackmailing, and mob lynching. So most of us think that only physical violence is a type of violence which we face, but almost 60 to 70% of people in healthcare face violence in form of verbal abusing, which we don't consider much. Next slide. So I'll be talking on understanding what and why violence occurs, present status of situation in India and abroad, what needs to be changed. So next slide. We have seen a lot of protests, but there needs to be certain changes which we also have to take care to prevent violence amongst us. And whatever I speak today, I am not sure that it will 100% solve the problems, but at least some corrections might happen, and we will be planned to know what to be done when such type of violence occurs. So next slide. There are 4 types of violences. Most of my references are from a book called as Healthcare Violence Prevention Program. I'll give you the reference. You all can go through that. Type 1 violence is committed by a person who is not legitimate. Like someone comes and steals something. During that time, he creates some problems in the hospital. He is not at all a patient or patient attender who comes into the hospital and goes. That is type 1 violence. Type 2 violence is by the patient or patient attenders or relatives. That is type 4. This is the commonest what we see. Type 3 is between the employees, either the previous employee or the present employee. And type 4 is the person who is committing that violence is not your employee, but he is related to one of your employees, and he comes to your hospital premises and creates some problem. That is type 4 violence. Next slide. There are a lot of surveys which says that 1 of 3 medical professionals, either it is doctor or nurses or the group D workers, they face violence in the healthcare establishment. Next slide. Are we the only country? No, because all other developed countries also face day in, day out hospital violence. Just an example, one of my cousin works as an accident emergency consultant in Australia. When I was discussing about this topic to him, I just asked. Then he said, no, we have a proper violence prevention program in our hospital, and there is something called as code gray, which they activate. Similar to code blue when there is a cardiac arrest in any hospitals, they activate code blue. Similar way, they activate code gray. Then I asked him, how frequently is this code gray activated in your hospital? Once in a month, once in a week? To my surprise, he said it is almost 4 to 5 times in a day. But it is not highlighted, and it is immediately taken care of. A small violence act is immediately taken care of. But here we leave it to escalate and then end up in problems. So various other countries also have violences in their hospital environment. Next slide. Why do hospital faces? Because healthcare employees work under constant stress and can also face emotional breakdown, due to which they sometimes lash out at the patients, which trigger violence. This can demoralize the employees and also drive them out of healthcare services. Violence can affect quality services and also damage the reputation of hospitals. Next. Hospital environment being highly emotionally labile state of patients and attenders, it is time of high activity because they want immediate care. They are concerned with their patient attenders, and certain rules and regulations of the hospital can also trigger certain amount of violence, like a liftman saying you cannot go up without giving them proper explanation can cause or initiate violence. Certain times we are not aware, the hospital administration is not aware that a patient is being shifted out, and the group D or the attenders of the hospital staff demand money, and that triggers violence. Lack of proper communication is one of the key important aspects, not only from a doctor, but also from each and every employee of his hospital. So training them in communications is very essential. Next point. Next slide. Most of you have seen this and experienced this in most of the 5-star hotels. Why did this happen?
5 minutes left.
Next slide. Next slide. This started after the, previous slide. Martin, previous slide. Yeah. This all checking in all star hotels, X-ray scanners, lot of security checks in these star hotels started after the Taj Hotel attack at Mumbai. But we have been seeing a lot of damages being done to hospitals, and what we have done, we see either we have to learn out of our own mistakes or by knowing what is going wrong with other establishments. Next slide. We see a lot of such damages, but still we have not tried to. Next slide. So this is the type of securities we have. I didn't want to give any wrong examples. The right image is of my own hospital, which was 4 years back. 3 years back. This was the security I had in my hospital. So I had to change it after I went on searching for it. The left side is a big medical college hospital. The security is busy with his mobile, and anything can happen anytime. So we are not changing ourselves to a certain extent so that at least the incidents can be brought down. Next slide. There are 5 core elements in violence prevention programs. This is the book what I was telling, that is Occupational Safety and Health Administration. In this, they say that management, leadership, and employee participation is the first key role in prevention of violences. That is, you take the leadership in preventing the violence, whether it happens or not happens, and then involve your employees in this prevention program. Then we have to also identify the hazards and assess where exactly these violences are occurring. Then we should plan accordingly how to prevent these hazards and also control it. And we should educate and train our employees on a frequent manner so that even if there is an incidence, we can take care of it, or it can be reviewed at a later date. Record keeping and program evaluation is also essential.
3 minutes left. 3 minutes left.
Any incidents,
3 minutes left.
any incidents which happens, it has to be reviewed after the incidents, and then appropriate steps have to be taken. Next slide. Employee surveys, as I said, we should have questionnaires after any incidents and take their feedback and try to improvise our training prevention programs. Next slide. Martin, next slide. Yeah. Previous slide. Yeah. Most of the time of violences are when we break some bad news. So many patients start at this point. We should know how to communicate with them, where to communicate, and what is the type of communication we have to do with them. Whether it is a doctor who is communicating this breaking of bad news or any one of your employees, they have to be really taught on the proper methods. Next slide. There is something called as spikes. It's a mechanism of breaking bad news, which says that setting up of interview. Most of us are busy in running around. We come out of the OT, we meet the attenders and just say it is okay, and then we rush off. Or something goes wrong in the ICU, we come out on the pathway, so we meet their relatives and we just say, he is very bad, it's very difficult. These are 2-3 words we say and then rush off. That is not the way of breaking bad news. We have to set an interview in a place where we make them sit. Then we understand what is their perception of the patient. Third is we invite them for a dialogue wherein whether they are interested in knowing the details. Fourth is sharing of knowledge. We share them all the reports, everything, and we connect with them emotionally and with the empathy. And then we make a strategy and summary of the patient details and give them also options. That is how breaking a bad news has to be done. Next slide. There are 5 stages of any person for that matter. Even I will go through these phases when any bad news is brought to my notice. That is, first is shock, denial, and disbelief. So convince them by showing them the reports. Blame, anger, and aggression is the second point. That is where the violence triggers. So support them there, listen to them, be calm. Third starts bargaining. They say he had some problem. They start bargaining and analyzing the situation. Be with them, stay with them with empathy and console them. Fourth is they start going into depression. Fifth is they start accepting the bad news.
0 minute left.
So what we usually do is we don't leave them. We leave them at stage 1 or 2, and then the trigger of violence starts with the family. So we have to be there with them till they reach 4th or 5th stage and then leave them. So most of the violences can be prevented. Next slide. Documentation is important. We have to collect all their ID proofs, and CCTV footage is very essential. And also ask your employees to record when there is any incidents simultaneously along with CCTV, because we never cross-check whether CCTVs are working or no. Next slide. Martin, next slide. Yeah, certain engineering changes we'll have to do in our hospitals. Display of boards on Violence Act or Zero Tolerance Zone. The reception should be deep enough and at a higher rate, higher length. And the pathways, exit ways should be easily displayed as it is done for fire exits. The CCTV is important. Security is also very essential. And fixed chairs, preferably all bigger chairs which cannot be easily lifted and thrown to damage the property. Next slide. Another last 2 slides. Next slide. Security again, as I have already told you. Next slide. Martin, next slide. Yeah, once we have this violence, what should be done? Previous slide, sorry. So immediately call for help from your friends, staff members, colleagues. on your WhatsApp group, and there should be a display of all the contact numbers on each and every place of the hospital where these things can happen, so that immediately, even if you are not there, somebody calls for help. Then response time is very important, because the task force has to be there within no time. Next slide. Handling of media, don't avoid them. Initial, when there is a violence, give them a brief information and give them a time to come at a later date once you are cooled down, so that you can gather your information on various aspects like CCTV footage, lab reports of the patient, everything. And mob also would have nullified, so that you will be calm enough. Call them into a room, give them all the reports and documents, whatever is essential, if you want. It is not compulsion if you want. And also, one important point is, whenever you are giving any points or interview to them, ask one of your attenders of the hospital to record what you are giving as a statement, because we have seen many times that only part of your statement is shown on TV, and then it is highlighted that you have given a wrong statement. So record, so that you have a backup that what statements you have given to them, so that in case they present it in a different way, you can file a defamation case against the media also. Next slide. So if violence occurs, WhatsApp groups are there, inform the police, lawyer, and the call for help. Next slide. Next slide. Usually in certain mobs, there are some troublemakers. You should identify them before, and also inform your other colleagues that these are the people who usually create trouble. They are common in any place for that matter. And don't forget to file an FIR. Don't comment that I'll pay by some amount and then sort it out, because by paying, you will, by settling, you will give a wrong notion that something has gone wrong from you. So don't settle off record. Next slide. So patient and public perspective has to be changed. They should be made aware that they cannot take law in their hand. If they can, we can also. Court verdicts against the culprits of violence should be made public in a larger way, and also take into confidence media people in highlighting things that hospital violence cannot be taken into hands. Next slide. There are various orders for one of the standing order 1018 is the example of Karnataka government, because no other state had this order standing SOPs for whatever Venkatachala sir said. Criminal negligence cannot be immediately filed and FIR without this SOP in our state. So please go through these standing SOPs. It is very helpful. It is as per the Supreme Court order. Next slide. Next slide. Next. So in spite of doing this, as I told you, it is not 100%, but definitely we can reduce the percentage of violence. Central law, just like that, for the violence against government service or atrocity cases should be brought in, so that people will be afraid of taking law in their hands. Next slide. So individual level, formulate and train your staff with violence prevention program, do on and off mock drills, and keep a logbook, involve in social activities so that people are accustomed and know you personally. Branch level, educate hospitals and help out other colleagues when in need. Form emergency team to reach out within minutes of need. At the state level, a lot of associations are bringing in strict laws and trying to bring in strict laws and maintain registry. At national level, again, the central law fight is still going on. So we hope that one day we'll have one strict law against violence. Next slide. These are my references. Thank you. Thank you for giving me this opportunity. We'll have a discussion at a later. Thank you, sir. Sorry,
you, Dr. Pavan.
1 or 2 minutes extra. Sorry.
Yeah. Thank you, Dr. Pavan. I request Dr. Shivkumar Kumbar sir to please present his slides and presentation. Martin, kindly put down the slides of Shivkumar sir.
Okay. There on the meeting. Yeah. Good evening, everyone. Thank you, Dr. Sivaram, Dr. Chandrasekhar, and Rajshekhar, and Dr. Hebsur, and my co-panelists for giving me an opportunity to share my views. Okay. Next slide, please. Next slide. Okay. Yeah. Just I would like to, in brief, I just would like to give an overview of the CPA 2019. Friends, everybody know that majority of the medical fraternity thought that CPA 2019 is not applicable to the medical fraternity because in the act, the healthcare has been removed. But ultimately, everybody thought that we were victorious in it, but it was a pseudo victory. So as long as the VP Shanta versus IMA case verdict, which was there in 1986 from the Supreme Court of India, it is still viable as long as it is there. We cannot escape from the Consumer Protection Act. With this, and I am very much sure that everybody should agree that yes, we are into Consumer Protection Act. Okay. And what is the territorial jurisdiction? The commission shall entertain where the complainant resides or works for gain. Earlier, the complainant has to file a case where the cause of action has taken place. For example, if the cause of action has taken place, surgery has taken Bangalore, he has to file in the Bangalore jurisdiction only. But this has been taken away. If the patient has undergone some surgery in Bangalore and resides somewhere in India, he can file a complaint against you from that jurisdictional area. And the pecuniary jurisdiction, yes, it has been changed drastically. So district commission is 50 lakhs. 50 lakhs to 2 lakhs is a state commission. National commission is more than 2 crores. Earlier, what happened? The compensation was asked, but the compensation this time is taken away. But it is the consideration of what you have paid to the, what you have taken from the patient. So if the consideration is up to the 50 lakhs, which you have collected, he can sue up to the many number of crores also. Okay. So in most of the times, district consumer forum, they are flooding up with the consumer cases even at the district level only because the consideration of the bill, what you take from the patient, very rarely exceeds 50 lakhs. So earlier it was the, now it has been taken, is acquired as a state commission, district commission, state commission, national commission. The newer thing is added is a mediation cell, means alternative dispute redress mechanism. It means that the case can be settled at the mediation level only. The mediation cells have created even at the district level, state level, at national level. So anybody can approach. A person can recommend to go for the mediation cell. If the case is settled in mediation, because it is voluntary between those two parties, nobody can go for the appeal. So with this, medical negligence result in a grievous injury or death cannot be referred to the mediation. This is very, very important. Probably I would say that it has given us some sort of relief to the medical fraternity. If you decide that, you cannot win this case in any level, so naturally you would have gone to the settlement. So rather than going for settlement, probably a mediation cell is open for medical fraternity also. So the newer things, what is happened is unfair trade practice has been included. Failure to issue a bill, receipt, disclosure of the personal information given in confidence, even to his family, unless required by law or in the publics, it is considered as the untrade practice. So they have quite one more word, unfair trade contract, requiring excessive security deposit, imposing unreasonable charge or obligations which put the consumer at a disadvantage. Again, it is taken as an unfair trade practice on the part of the medical fraternity, and we're all liable for that. Next slide, please. Next. Yeah. So with a brief introduction to the Consumer Protection Act, having confirmed that you are into the Consumer Protection Act 2019, now I will talk something about the medical legal cases. What is an MLC? Any case of injury or ailment where the attending doctor, after history taking and clinical examination, considers that the investigations of a law enforcing agency, this is most important, that is the police or the court, are warranted to ascertain the facts and circumstances and fix a responsibility regarding the said injury according to the law, is called as a MLC. Registration of a case as MLC with police. It is purely responsible of the doctor to decide as to when to label a case as a MLC depending upon the fact and circumstances which caused the grievous injury, rape, trauma by informing the police. Even at the given point of time, if you do not come across, if you do not suspect these things, yes, you may not have made it as MLC, but having gone after 2 or 3 days, if you smell something must have been there. So probably again, we can make it as a late MLC. No difficulty arises in registering a case which are brought by the police. Very much certain, because they themselves bring you to make it MLC. Difficulty arises when a person injured or sick comes himself or brought by his relatives who try to conceal that violent or criminal intent or medical legal intent. In such cases, attending doctors shall suspect foul play and make MLC and register with the police. Doctors should not entertain the request for not registering a case with the police. Many times it happens if patients or relatives or political pressure or colleagues or friends, they request you not to make it an MLC. Please do not get into that. Doing so may amount to hiding the crime or harboring the criminals under section 201 and 202 of IPC. Any failure to report such an occurrence as MLC may invite to prosecution of medical fraternity under section 176 and 202 of the Indian Penal Code. Caution for not doing PM. In MLC cases, written and signed a note from the relatives about not wanting PM. It has no legal sanctity or legal validity. You have to ask for the post-mortem. Next slide. Next slide. Yeah. Whether in all MLC, PM should be done or not. Once the patient dies unnatural, the body becomes the property of the state. Very, very important. Once the patient dies natural death, the body becomes the property of the relatives. Unnatural death requires PM, no doubt about it. The power to order post-mortem is vested with the police, but not with the doctors under section 174 of the CRPC, and not with the doctor, as I told you. Doctor has to just inform the police regarding the death. No consent required from the relatives to do the post-mortem. The investigating police officer has the power to hand over the body to relatives without the PM also. It is his discretion. Okay. But the medical officer does not have this vested power in him. Because of any future inquiry, doctor may be wrongly framed for not doing a PM and he may lose his job or he may be suspended with his registration also. How soon to inform the police? This is very, very important. Supreme Court has clarified that police activities can wait, but life of a victim is important, paramount. Hence, treatment should be instituted immediately. Then you can inform the police. So, how exactly is the reasonable amount of time is required to inform the police? Some judgments talk of reasonable time means as soon as the emergency care is over and the patient is stabilized, then procedure of informing the police may be started. If the patient is gasping here and rather than treating him, if you are informing the police, so again it's a crime, a deficiency, and neglect on the part of the service. It is the against ethical practice of a doctor. The medical legal documents, all original copies of the certificates, reports issued for medical legal purpose are to be preserved till the finalization of the case in the court of law. Next slide, please. Next slide. Yeah. Some important cases in general surgery. Yeah. Appendicitis for which laparotomy was done. Appendix was normal, but gallbladder was removed. Post-operative patient died. So it was proved that doctor exceeded his capacity to do the surgery and he tried his best to remove the gallbladder. Anyhow, has opened the abdomen. So it was found to be negligence. Appendicitis not operated for the time of emergency, delay for the want of consent, but refused to give a consent which was not documented. So doctor claimed that I did not operate because the patient did not give the consent. The patient said that yes, then he never asked it. So refusal for the consent is also more important or equally important than taking consent for any of the surgical procedures. So in appendectomy was done, second operation done without the consent. So negligent held. So if at all you are operating or reoperating or re-exploration, don't think that the consent what you have taken yesterday or day for yesterday was sufficient. No, it is not at all there. A fresh consent has to be taken. Yeah, a large size artery forceps is a very, very documented case left behind during the laparotomy, head negligence. So there was a splenectomy, died the next day. It was cremated. Then the relatives went for the collection of the mortal remains. They found the forceps, and ultimately they went to the police station stating that yes, this is what we brought along with the bones, and it was found that the forceps were left in the abdominal cavity, and they were found a negligence case, and the CDRC in 1996 awarded a huge amount. That while doing ERCP with the CBD endoscopy, yes, the patient was given a propofol by the anesthetist, cardiac arrest occurred. It was not noticed in time. Patient went into the irreversible hypoxic encephalopathy or coma and died. It was well negligent on the part of the anesthetist as well as the surgeon who permitted the anesthetist to give propofol without any diligence. The compensation announced from 10 lakhs to the 47 lakhs at the National Commission. This was in Hebsur Hospital, Hyderabad. So non-toxic edema of the thyroid, yes, intraoperative there was arrest, could not be wired, but surgery continued.
0 minute left.
Yeah. surgery continued. Okay, patient was not even recovered from the cardiac arrest, but however, surgeon insisted that yes, you can go ahead. Anyhow, patient pulse BP has come up. I can finish in 15-20 minutes. So ultimately, the patient died. The court categorically asked, when the patient was revived, why did you go ahead with that? Probably since it was elect the case, you could have postponed it. This has happened in 2001 in Karnataka only. Dr. V.K. Kini versus Dr. Vasudeva, and they were awarded to the 1:3 ratio between the anesthetist and the surgeon and anesthetist. Here, complainant failed to substantiate allegations made in the complaint regarding the medical is held. A complaint lacks the merit and was dismissed afterwards. Next slide. Yeah. Thank you very much. I love to interact with any of the questions. I think I did not exceed more than 10 minutes. Thank you.
Sir, thank you so much, sir. Thank you. We have lot of questions in the chat box.
Yeah.
I think so. We'll just go by one and I request the concerned panelists to answer them. First is we have had a email from our senior most surgeon from Shimoga, Dr. R.D. Prabhu sir. He is asked how long we have to maintain the records. I think so. Partly this has been answered by Dr. Prabhakar, but still I request the medico-legal expert, Dr. Shivkumar KUMBAR sir, please let us know how long we need to maintain the records.
Yeah. Most of the cases, they go to the consumer cases. The limitation period for the Consumer Protection Act is 2 years. But however, if the parties can convince the court or the president of the consumer, the member, why it has been delayed, so he can just move in condonation application to convince the court. If the court accepts it, yes, even after 2 years, a limitation period, we may have to keep it. So for all practical purpose, what I suggest is you have to keep at least for a period of 5 years any of their case papers. And earlier, MCA had not put the how long it should be kept. It has kept. It has mentioned only about the IPD. But as per the NMC, the OPD papers have to be kept for 3 years. IPD papers have to be kept for 5 years, and medical legal cases till the case is disposed are up to the 30 years. But when it comes to the Consumer Protection Act, even though it is a limited period is 2 years, I request everyone to keep the medical records at least for a period of 5 years.
Sir, what about the OPD papers? Most of them don't maintain those OPD papers.
Yeah.
It is given to the patient. Is it okay?
No, sir, you have to maintain.
See, I'll tell you. See, earlier it was to be acceptable, but when you give a OPD patient to the patient, okay, anything can be changed. Anything can be changed. They can produce this to the medical council or to the consumer courts also. The best thing is, even if you give a prescription, you have a carbon copy of it or in the what you can say computerized format. Okay. So this is the name of the
actually they are insisting digitalization.
Yeah, please.
Yes, sir. The best solution is going with electronic storage of all the documents, sir. Because you never know, you keep it in the storage and something goes wrong, it is burnt or something can happen. So best way is to have your electronic record in place. You can scan all the documents and keep it.
Yeah. If we fatally want to dispose of our case paper, okay, I give an advertisement in the paper stating that so and so numbers case paper will be destroyed. If anybody was interested for any purpose, income tax or legal purpose or whatever it is, insurance purpose, they can come and collect it. So one is the English, other one is the vernacular language. They can be given in the newspapers. They can turn it off or dispose it off. Next, please.
Sir, yes, sir. Thank you, sir. Next is Dr. Preeti has asked regarding the second case, that is a mop in the abdomen. How should the second surgeon handle such cases? Should he or she be honest about finding the mop and protect the first surgeon? I request again Shivkumar sir to please answer this.
Yeah, this is a double-edged weapon. I think Dr. Prabhakar and rest of the panelists will agree also. To protect the interest of the colleagues. Most of the times we don't disclose that there was a mop. But however, your colleagues, the war boys, sisters, one or the other day, if they have made a CC recording something probably in the soup, I think the best is to be honest at particular point of time and tell them what exactly went on. Ultimately, the colleague's interest is also important. The patient's life is also important. But again, it all depends upon the skill or communication skill of a surgeon who does the second operation.
Fine, sir.
Can
Thank
I
you.
answer, please?
Sir, Dr. Ravi Shankar has said as as a lesson to all our colleagues, we should ensure that we do not comment negatively or on the fellow surgeons as much as possible. That is a real truth. We should avoid commenting on any other surgeons other than yourself. Whatever you are doing, you please talk about it rather than talking about other surgeons.
Yes, yes.
Next, I request Dr. Venkatachala to answer this. Dr. Naz Sheikh wants to know, do you have any professional indemnity insurance? How valid it is?
See, when, as you, after the Amri case, you saw that how much the court can order. They saw that hospitals will have 10 to 20 crores as professional indemnity. The lawyers know, the judge will know, and let's not discuss who is hand in hand in the case discussions. Okay. So the lawyer, the judge, the court knows that the hospitals have 10 to 20 crores of professional indemnity, whereas we have 1 to 2 crores. So the court is smart enough, they will tell you to pay 1 to 2 crores and they will ask them to pay the hospital to pay 10 crores. So we should be very clear that we should have our own individual professional indemnity insurance, even if the hospital has an indemnity. Because someday you're shown the door, you're out of the hospital, and you cannot practice without an indemnity insurance, and there should be no discontinuity. Your indemnity insurance must continue. I renewed my insurance today. They said if you change the company, like AMC or IMA, anywhere, I can go to any place. They said, sir, whatever cases happened in the retrospective, somebody files a case 8 years or 7 years, if some complication happened earlier, if they file a case, we cannot protect if you break the continuity. So I have to continue with this policy also, as well as take another policy. The another intelligent thing, information given to me is that you cannot have, if you're a skilled doctor, you cannot have 2 or 3 cases running simultaneously against you. So don't try to split your professional indemnity of 1 crores or 2 crores into 10 pieces or 4 pieces. Like they saying that 25 lakhs. 25 lakhs is not what the court will order. The court will order usually 1 crores or 2 crores. So I have made my professional indemnity as 1 crore single payment. 1 crore single payment means only 1 crore total will be paid by the insurance company. My premium is more, but 23,000 I paid today. If I go for 25 lakhs each case, 4 cases in a year, splits, my premium may come to 10 to 15,000, but I don't want that. You take a professional indemnity of 1 to 2 crores and make it a single payment annually. So that is,
Fine.
you should always have your own professional indemnity.
Thank you, Venkatachala. I request Pavan, please highlight about the IMA KPPS indemnity. Can you just give a brief about that?
Yes, sir. There are a lot of private indemnities for individual as well as for hospitals, as Venkatachala sir told already. IMA Karnataka Professional Protection Scheme, it is similar to indemnity scheme itself, but it is a mutual benefit scheme. You become a member to that. If you are an IMA member, you can become member to KPPS scheme by paying 3,200 rupees initially, and subsequently every year 500 rupees is the renewal. But believe me, first 2-3 years it will be only a renewal, or maybe 4 years or 5 years. You don't never know that the yearly renewal you will be paying only 500 rupees. And the amount of coverage given, including the legal fee, everything is around 1 crore. And later on, if any, during your membership, any cases are awarded, then that will come as a contribution amount. So if there are more number of people, the contribution will be less. So as and how there are more number of people, the contribution amount will be less.
Fine. Pavan, what about if at all I want to insure for 10 crores? Can I take multiples
No,
of
sir.
3,200?
No, sir. Individual will have one insurance, but you can have private insurance also along with this.
Okay.
So you can claim from that as well as here.
Thank you. Because Dr. Ravi Shankar has said The second case, people of res ipsa equitur. Can Dr. Kumbar sir please tell us what about the res ipsa equitur?
Left ipsa equitur
I
is
request
nothing like
everybody to mute, please.
the accident speaks itself on the face of it. Okay, or else you don't need to have any evidence. Okay, and it tells on its own what exactly went wrong. For example, instead of operating on the right side, you operated left side. There is no reason to prove it. Okay, it itself speaks. Okay, this is a left ipsa equitur, and mopping the abdomen as some sponge. So definitely it is taken as a left ipsa equitur in the court of law. Okay, we cannot escape. We cannot escape from this. So this is the left ipsa equitur.
Fine, sir. Sir, and there was a question by Dr. Satish regarding the criminal case should not have been registered by the police in the first case as per the guidelines of Supreme Court order in similar cases. How valid it is and how to go about this?
Yeah, sir. When it comes to the any complaint in the police station, okay, even the police people do not know about that. Okay, where exactly which section has to be registered. Okay, most of the times they register under 304. Actually, all medical negligence cases have to be registered if they are criminal intention or criminal negligence at 304A. So most of the police people, they do not. Okay, they try to push you in this. And 304A, as per Supreme Court guidelines, before registering a FIR, they have to take an independent expert opinion. Most of the police, they do not treat. I have 3 cases in the last 2 years. Okay, the police people have registered FIR and they filed a charge sheet. And in the Dharwad High Court, I made to squash all the FIR cases best because they did not have an expert opinion.
Sir,
Okay, next week, probably next week,
our
one more
state
hearing is there.
Yes, sir. Our state has that SOP. So
Yeah.
I request all the members to have a copy of it so that any of your colleagues or anybody goes through this situation, you can show this SOP from the DIG of Karnataka that they cannot file an FIR against any medical professional under 304A.
Yeah.
Without a medical board certification that this is a gross negligence or a gross criminal negligence.
Even last year in somewhere Dharwad, a dentist was booked under 305 in spite of showing this case. Okay, and almost he was about to leave his practice as a young fellow, but somehow we could see to that the FIR is squashed in the Dharwad High Court. And the very next day, as we thought of it, he went to the consumer court. Automatically, we lost the consumer cases and we won the case even in the consumer court also.
Thank you, sir. I request Dr. Pavan kindly post this SOP in our website so that it will be available for everybody.
I'll
So
forward it to
it
you,
will
sir.
be useful for all the members of the KSCASI.
Yes.
Thank you. And next question is Dr. Preeti. Until what time the procedure or complication can be the case filed against the doctor? It's difficult to save the video recording of the consent and conversations with the patient and attenders. How to go about this, sir? Dr. Kumbar, sir.
I did not understand. Can you repeat? Yeah.
Sir, until what time the procedure or the complication, anybody can file a case, and in case of the difficulty of video recording of the consent and conversation, if it is there, how to go about that?
Yeah. See, earlier, the limitation period would have been start from the day of surgical procedure, from day of surgery or procedure, what you have done it. But of late, okay, it has taken back the word. So the limitation period or day after limitation starts from the day when the patient comes to know about the complications. For example, the surgery is being done today. After 2 years, if he thinks that, okay, renal colic, again it's appeared, something went wrong, other things. So when he notices that complaint, from there onwards, the limitation period will start for 2 years or 3 years in consumer court. So it is very, very difficult telling the patient that after this period, even if you are recorded, you are not eligible or you are not responsible for that, something goes wrong. That is against the public policy. This kind of videos will not be valid in the court of law, sir.
Thank you, sir. Thank you. And Dr. Shivaram, our president, sir, has clearly said that we have to follow the safety checklist as the surgeons or any doctors practicing. The safety checklist have to be, the protocols should be followed, and that is going to benefit all of us. And
Dr. Kumbar, sir.
Yeah,
Dr.
please tell me.
Kumbar, no, if a patient develops a complication after 8 years or 10 years later, still they can go to court and complain?
No, sir. before admitting the case in the court, they see the probability of that complication. Okay, if it fits, okay, if the courts, if the person can convince the court that this complication can happen even after 8 years, yes, definitely he can file a case. But ultimately, it is we who have to defend ourselves in the court of law with a lot of evidence and material and arguments.
Sir, actually, in most of the psychiatry patients,
Yes.
usually they'll develop after 8 years or 9 years. So such cases have come to the KMC.
Yeah. So even I've seen a patient. I have been handling that case. The patient has undergone spine surgery 8 years back. Okay, and somebody has asked him to do one more surgery for stenosis. So after 9 years, he has filed a complaint. Okay, so I'm handling that case, but case is admitted that case even after 8 years.
So that's why keeping documents even for 8 years or 10 years becomes very important.
Very, very important. Yes, Pawan also said it. Yeah.
Electronically, it is very easy and
Easy, yeah.
less space occupying.
Yeah. Right. Next.
Even in pediatrics, the law says that they have to keep it till the child attains 21 years. Majority of age. I have one case, a patient is undergone a circumcision about when he was 9 years or 12 years. Now he's already 20 years plus. Okay, they have filed a complaint against the surgeon who did the circumcision because patient had a hypospadiasis.
Oh, God.
Right,
Okay, sir.
Hebsur. Next.
Sir, there are some other questions regarding, sir, discharge summary, medical certificates, all these things. Can Prabhakar, sir, can you just tell us briefly, or
I think
can you?
He has covered. He has covered.
Yes, sir.
There is nothing.
Sir, can we get this protocols in the website of our
Yes, sir. Actually, this one usually in the KMC we will give one book called the Code of Medical Ethics.
Yes, sir.
Yeah, in that they mentioned actually the certificates, in the Appendix 1 and Appendix 2 like that. So in that format only you have to give the certificates.
Sir, we can get a soft copy which can be put in our website.
I'll put tomorrow only. I'll just.
That will be nice, sir.
We'll upload, sir. We'll upload the same thing in the website.
Sure, sir. And consent in patient's own language is a must, or how should we go about this, sir?
Sir, actually, informed consent means it should be in the patient's language. If the patient cannot give consent in writing, at least you should explain orally and you have to record. Because the patient should understand what you have told. That is more important.
Correct.
Plus, tomorrow they will argue that yeah, they forced me to sign, so I signed. So
Yes,
for written this thing, they will not accept. So usually, I mean, printed format, they will not accept. So you have to write and
one thing what
I
we
would like to add here.
Prabhakar sir, one
Sir.
thing, court will say we cannot write 4 pages for every patient. Like previously, we used to write the sub-registrar office registration thing. Everything was handwritten. My grandfather used to write. Now we don't write. Everything is typed. Whatever you do, you type. But what was happening, what the court questioned was, you are taking a common consent form for everything. Any complications, anything, cardiac arrest, respiratory arrest.
Exactly.
They said certain complications you have to write, certain things in the patient's own language. If you don't know their language, no, they will write. Or take video consent. Don't
Yes,
write like we have for cholecystectomy a separate consent, for hernia separate consent, for hemicolectomy separate consent with the complications written. So
No, you have to-
then you will have to write something
No,
in
no.
between.
In the informed
totally
consent means from the diagnosis you have to explain.
Correct. That is what
Diagnosis,
with
then the
that.
treatment options. What are the treatment options, and which treatment you are opting, and then why you are opting that treatment. Then what are the complications of that? So
Correct. And death
everything
must
should be
always
informed.
be a part of the consent form, whether even if it is a small true cut biopsy or something.
Exactly.
And
Even for
everything
blood
must be
transfusion
detailed,
also for that
documented,
matter.
discussed. For high risk surgeries, at least start taking video consent and document
Yeah.
it. Nobody can, when the camera is in front of you, then they will not deny. When they have signed the consent form, patient sign is very important. There have been 2 instances I had to extubate the patient or reverse the patient and take consent or postpone the surgery. Without the patient's consent, except for 3 indications, patient is minor, patient is mentally retarded, patient is incapacitated, unconscious, or cannot sign because of something.
No, sir. If you find an intraoperatively, the patient is life-saving important. Okay, for example, you will open it for abdomen, something else. If you find a gangrenous ovaries or gangrenous fallopian tube, okay, there is no need for the reverse the patient, take the consent. Okay, if you think that intraoperatively, that the life of the patient is important, there is no need for the consent and reverse the patient, take the consent.
Sir, we write one line in the consent form, videography is included. There can be that for some reason we may have to close because of some unavoidable reasons. Third thing, there can be an additional surgery with the intent to save the life of the patient. Supreme Court had released a consent format. You cannot have a defined consent format, but they said, okay, use this prototype. This is the consent form which most hospitals use. In that it is written, life saving, for the purpose of life saving, I can do something, but I can remove a part of the colon, but I will not go and remove a kidney without consent.
Thank you, sir. Now we have one more question. I think so. Rest all other chats have been repeated and answered. One is, what is a police surgeon?
No, actually in
What is
Ahmedabad,
that?
we had this police surgeon. I answered it already. For everything, all the documents are with that department. All MLC, everything, X-rays, everything are with him. CT scan, everything. If I want to refer the case for some medico-legal problems, if there is a court case, I will write a letter to him. I will take it to him and I will get the file from him. If the patient is admitted, I will write a letter to him. Sir, this patient has been, he will inform the police, he will manage everything so that I don't have to waste my time in handling the legal issues. The legal issues are taken care by that person. Many hospitals have a lawyer who handles legal cases, but in our hospital, we had a doctor who will manage all these things.
What is that?
He is a CMO.
Some places, the
Police
forensic
surgeon.
experts are doing this.
Yes,
Some
most
places they are getting tied up with the hospitals as medical legal experts, and then they are handling these medical legal cases.
Hebsur, that is police
Anything they
surgeon.
are.
What is the name?
Sir,
What is that?
sorry. There are a lot of crosstalks. Let Pavan Kumbar sir is telling something. Let's just.
Yeah, that police surgeon, right? You wanted to know about police surgeon, right?
Yeah, correct.
Yeah, police surgeon is a word coined in most of the metropolitan cities, and he is nothing but the forensics expert, okay, who is in the category of assistant professor, associate professor, who is usually appointed by the government to look into the medical legal cases. So he is called as a police surgeon.
Fine, sir. Dr. Dayanand Nuli sir had asked this question. I think so. We have got the answer, and most of the chats we have received are all answered. And I think so. We had an extensive discussion on this. This topic is never ending, and we had given very little time for this. That is just 10 minutes. And in that 10 minutes, they have tried to give us a lot of take-home messages. We sincerely thank all the four panelists, Dr. VENKATACHALA, Dr. PRABHAKAR sir, Dr. Pavan, Dr. Shivkumar Kumbar sir, and all of them. Thank you so much. I think so. With this, shall we?
Sir. No, Kalavani madam has raised her hand. Scientific chairman to conclude.
Dr. Kalavani.
Fine. Kalavani madam, you want to say something, madam?
Unmute, please.
Unmute, madam.
Sorry. I just wanted to ask one thing. The consent in their own language, many a times we are getting patients from all states now. There it becomes difficult, no, sir. We usually have a translator, their own relative as a translator.
That's why, madam, you have to record. Video record is better.
Fine, sir. Fine. Thank
Can
you.
I add here, sir? There was an exercise which happened last year when during Dr. Abhay Dalvi sir being a chairman and the National IMA president, both of them together had, there was a company which was doing this consent, video consent. So I was also part of it for certification and feedbacks. It was a really good one that you give a link of that procedure to the patient, and at their leisure they can go through with animations of the surgery and other things. They go through that wherein the complication, everything is explained. Once they have viewed it, there is a document which gets generated of the procedure and the available complications, and also written that this video has been viewed by this person, and he electronically signs as well as manually signs on a printed document at the end of it. So they have sufficient amount of time. They are going to make it even in your all different local languages.
Right. I think this topic is very, very interesting. There will be many questions and also solutions. We can create awareness and we may not be having solutions for all the problems. Maybe we can take the last comment from Dr. S. Rajan, and final conclusion by Dr. Siddesh. Then we'll close. Ravi Shankar, next time.
Thank you for the opportunity. Just a query to find out, any foreign body removed from an abdomen or from a person, like a wedding ring from the stomach, is whose property? Is it hospitals, doctors, or exactly the patient?
Let the court decide, sir.
But I keep
You want it.
Remove,
You want it.
like the tooth or the pin or anything.
Sir, we have to give it to sister, sir.
She's thinking I'm getting married to her, man. Come on.
Yes, sir.
You remember Kamal Hassan's movie, sir?
Yeah.
Watch is inside his tummy. Should not happen.
Anyway, the genesis of this question is that when you have mob, please don't give it back to the patient or anything. Send it for histopathology and say all procedures, all things removed from a person's body should go for histopathological examination. Kindly do not hand over mops and other things to the patient, please.
Yeah, that's
Thank you very much.
Yeah,
you did, sir. You did say that. Yes.
Thank you, everybody. Dr. Siddesh. Thank you for joining and your final comments.
So nice. Thank you for giving me opportunity, President Dr. Shivaram. And I can see this is a popular program as expected. And I really congratulate the law office bearers of Karnataka State Chapter. I'm taken up this exercise. I know this is not enough. It is just an eye opener. The subject is so wide and everyone has their own view and their own problems we have come across. Just to say, I had always thought if you stick to your ethics and you have got a real good conscience of doing only good to the patient, that is the best insurance you have with you. That is my belief, and which always I believe that is what protected me for throughout my career. But you can't believe that at the end of 35 years of practice, I had my first litigation. So maybe the times have changed. Only sticking to the ethics and practicing principles in surgery, what we have acquired, is not just enough. So we need to take care. Times have changed. And such meetings like this always help us in preparing ourselves. My certain couple of suggestions is be empathetic to patients, whatever their attitude is there towards you. Attitude of the patients have changed over course of time. I'm sure senior surgeons would agree with me, but that should not lead you to change your approach to the profession or the patients. So that empathy, we will stick to our own ethics and standards, but we need to take care. The documentation is the most important thing. There are a couple of things as an association, what locally you can do is that make awareness programs like this, involve occasionally, once in a year, the MAHAN, the Mysore Association of Private Hospitals and Doctors. What we do is we call the police people and the media voluntarily for sensitizing them. The reason is, as been put forward by our expert who is here in the panel, Dr. KUMBAR. He told police are not aware about the law. Can you believe this? They file an FIR which is not correct. And then you need to go through the whole exercise of fighting it in the court of law to get the FIR quashed. But that doesn't exempt you from getting into the litigation for which they have filed FIR. So, but whatever it is, if you have done this exercise, and we always constantly do this whenever there is a commissioner who gets changed in the city, or we hold a meeting with them and we request them, a single point contact person in case of emergency, any doctors can approach. So there will be one single point contact of a self-help group from the MAHAN group. At the same time, the police have 24/7 one phone number where that person who is there at the other end of the phone, we is sensitized to receive a call from a MAHAN colleague. So if suppose there is a complaint and the police starts filing an FIR, we tell the grieved doctor to contact the self-help group head, who in turn will contact the single point contact on the part of the police. And they are sensitized enough to inform the concerned police station not to file the FIR, so that they can take the correct legal path. So that is the biggest relief anybody at that hour of, and that is one thing which I would suggest. Number two, we need to stay in group. The self-help group of the Mahan always tries to form a small group which is nearest to the person in crisis, and we rush to that place, at least stand with the person in crisis. So that is the other thing what we do, which will dilute the situation, number one. And one of the doctor may be in conversant with the patient's attendants or a group who can pacify them. Third is the morale of the surgeon or the person in question will always be boosted. So these are certain things. There I can go on quoting so many other things, but at the same time, my request is, I had put up a question in the chat box. What is the time duration maximum where a complaint can be raised? I'm sure there is a time bar, but I don't know, even at the end of 4 years or 5 years, a complaint is registered by the local authorities. Like I don't know whether it is right or wrong, but you can always fight it out. But is there any real time bar? I really don't know, where beyond that complaint cannot be raised. So that is my observations. Thank you for giving me opportunity. I'm sure a lot of, and this discussion, if it is recorded and is available on the link can be provided on the website of the Karnataka chapter. People at their leisure can visit and get the information.
Definitely.
At the same time, it is highly appreciable that that SOP and certain things like that, they are also shared.
SOP, all the things.
Thank you, President, for giving opportunity. Good night.
Thank you. Thank you, Dr. Siddesh. I think one most important is the indemnity, professional indemnity, at least for 1 crore. All surgeons should have, apart from whatever empathy, whatever ethics, whatever is there. Most important, legally, we should have a professional indemnity. With these words, let us conclude this wonderful meeting. Thank you, everybody, for joining, interacting, asking questions, sharing your experience. And we will continue this in the WhatsApp group and also in our website, and sharing our whatever knowledge is available in the all the other forums also. Thank you very much. Have a good night. Thank you very much.
Sir, one thing is,
Good night.
Thank you, sir.
the same thing, recordings will be uploaded by tomorrow in the YouTube. KSCASI, we have a YouTube channel. So you can, we'll provide the link and you can see the same thing from
It's a live stream. The thing probably is already on the YouTube.
No,
We have to edit and put it.
Yeah, tomorrow we'll edit. Tomorrow we'll edit.
Second thing is that the chat messages, will they be seen on the recorded area or in the YouTube? If they are not seen, can we at least copy paste and share it with the all the members by email or?
Can do, sir. Can do.
Martin, please take care of that. Right. Thank you. Good night.
Thank you.
Good
Good
night.
night.
Thank
you.
Thank you, everyone.
Excellent.
Good night,
Very
everyone,
nice.
sir. Good night.
Thank
Good
you.
night.
Good night.
Thank you, all the panelists. Very nice.
Thank you,
Thank
sir.
you.
Good night, sir.
Good night.
Good night, everyone.